in this panel discussion. Professor Musisi is our panelist this afternoon. He has a long-term experience in mental health care and research, and I think administration spanning from Canada to Uganda, the East African Federation, and even in Africa. So he's going to be taking us through a very important topic, mental health problems in HIV and AIDS, the bidirectional relationship, he will tell us why this is very important. So, yeah, Professor Musisi, we have health professional students from Lira University, Northern Uganda. I think the programs there are midwifery, nursing, counseling, and public health. And then Bishop Stuart, there is nursing, public health. And then Bara University, we have MBCHB, pharmacy, MLS, physiotherapy, pharmaceutical science, and also the nursing program. So wow. that is your audience. It is mixed in terms of.
That's a very, very valid audience. Thank you.
Yes. So we are really proud and very privileged to have you, Professor Musisi, facilitating this panel discussion. So please go ahead. Participants, we shall have questions at the end. So you can post your questions on the chat, but there'll be an opportunity for you to speak. So Professor Musisi, please go ahead.
Thank you very much for that elaborate introduction, Professor Maling. We are going to be talking about mental health in HIV/AIDS, a bidirectional relationship. Now, it was advertised as mental health and HIV/AIDS, a bidirectional relationship. It's not really the mental health, it is the mental health problems that have this bidirectional relationship. And my slides are not moving. I don't know why.
Prof, please click in the middle, then the arrow keys will work. Click in the middle of the slide.
Click in the middle of the slide?
Yes, there where the arrow is.
I have clicked in the middle, still not moving.
You click, then you use the arrow keys.
I click and then I do what?
You use the arrow keys up and down after clicking in the middle of the slide.
Yeah, okay. So why bidirectional? The reason for being bidirectional is that mental health problems predispose to HIV/AIDS and complicate HIV/AIDS. But also HIV/AIDS creates its own mental health problems, which again got to influence the care of the HIV patient. These mental health problems may occur before the HIV infection and predispose to HIV. They may onset as a result of HIV infection, hence being caused by HIV or its treatment. They may increase after HIV infection. They cause complications in HIV/AIDS. They compromise care, outcome, and quality of life of people living with AIDS. They compromise prevention efforts. They span the whole spectrum of psychiatry, and they may occur at any age. So they need to be correctly diagnosed, treated, and prevented. So we can classify them, therefore, as those psychopathologies before the HIV illness. Or the second class are those due to reaction of getting HIV. And then the third category are those disorders consequent to the HIV/AIDS itself or its treatment. But that's not all. There are also mental health problems in individuals affected, not infected, but affected by HIV/AIDS, like family members, children, spouses, orphans, widows, caretakers, co-workers, friends, neighbors. That last category we shall not tackle. That's not bidirectional. It is the first three that are bidirectional. So we shall begin with what I call premorbid psychopathology, the mental disorders occurring before one even gets HIV and how one adjusts to it. So these premorbid conditions are they make psychosocial risk behaviors for HIV infection. They may also complicate the post-infection clinical picture. For example, you can imagine somebody who is an alcoholic getting infected, and you don't know what is causing what when they get confused. They impact treatment and prevention outcomes. So we call them premorbid behavioral psychological adjustments. And examples include personality disorders, high HIV infection risk groups, pre-existing psychiatric illness, substance abuse, and those populations which are at risk of getting HIV, and their vulnerable populations like orphans, marginalized communities, conflict communities, the elderly. So let's begin with the personality disorders. Personality disorders are enduring maladaptive ways of behaving and coping with life's challenges, usually by non-conformity to society's expectations and rules, adjusting stresses or relating to others. Individuals with personality disorders are more likely not to comply with treatment recommendations, and they tend to break rules. They abuse substances. They tend not to practice safe sex, and they present as difficult patients in hospitals, being manipulative, violent, and social, dependent or avoidant, avoiding responsibility, for example, to care for themselves. Therefore, they present problems of treatment and non-compliance when one gets HIV infection. So you see these premorbid are already now going to the infection picture. There are two types of personality disorders that tend to be most important in this situation. As psychiatrists, we call them cluster B personality disorders, those which are very dramatic, like borderline personality disorders. The borderlines don't obey rules. They tend to be manipulative. They're always inconsistent in relationships. They abuse drugs. They become unsocial. They don't hold down jobs. And social personality disorders don't obey rules, and they don't respect the rights of others. Then there are those who are self-centered. We call them narcissistic personality disorders. And then the histrionic personality disorders, who are dramatic. The cluster C personality disorders tend to be very anxious, like they avoid responsibility. When you tell them to do something, they feel it's not their responsibility to do that. The dependent ones don't like to do things. They leave it to the others to do things for them. And then the obsessives are too concerned with order all the time. So these premorbid mental disorders also include pre-existing mental disorders. And we are going to talk a lot about this because these are mental illnesses occurring in the context of HIV/AIDS. And most of the work that I'm going to be talking about has actually been done by us, including some people in your audience. For example, we have patients with severe mental illness and like schizophrenia or bipolar disorder or delusional disorders. Professor Malling in 2011 first studied them and found a high prevalence of HIV/AIDS in them. Another work, again working at Butabika, Lundberg, found that when you took patients with HIV/AIDS, a number of them had severe mental illness. And then there are the affective disorders. These were studied by Professor Nachimori with bipolar disorder. Those with depression were studied by Professor Akena. Again, I'm going to tell you more about these disorders as time goes on. And then we have those patients with the organic mental disorders, dementias, mental retardation. These were studied by Professor Nakasugia. Again, you hear about them. Then you have individuals who abuse substances like alcohol, illicit drugs, prescription drugs. Again, all of these affect the outcome of HIV/AIDS. Then we have high-risk groups. These high-risk groups tend to be more vulnerable to getting HIV infection. For example, sex workers, people in fishing villages, people in the military, taxi or border drivers, bartenders. But also those people in vulnerable populations tend to be at high risk of HIV. Orphans who are left with no care of parents, poor communities, urban overcrowded centers, conflicted communities. So now let's talk about the HIV patient or the individual who gets HIV and then now develops mental health problems. This is now an individual who did not have mental health problems before, but is now going to get mental health problems because of getting HIV. And we begin with the acute psychological problems or reactions. In other words, one gets news that they have had HIV/AIDS. What happens to them? Psychologically. So in here we have adjustment disorders, we have acute stress disorders, we have post-traumatic stress disorder, and we have a tendency to suicidal ideation. So these psychological reactions do not connote brain pathology. The brain is not yet diseased, but are just an emotional psychological reaction, creating behaviors or behavioral reactions after hearing the news that you have HIV/AIDS. This is because your ego defense mechanisms become challenged to cope. So why should somebody react in a very distressed way to the news that they have HIV? First, HIV is a sexually transmitted illness. So it tends to be secretive. It is associated with social, cultural, religious, and moral judgments like sexual looseness, sexual orientation problems, or people begin to wonder about your character integrity. So it becomes highly stigmatized, both by you, the individual, for fear, and by society for fear of you. And because of this, by the way, including health workers, it tends to impede access to health care. HIV/AIDS is also infectious, highly infectious. Because of this, there is fear of contagion. Especially this was more so in the beginning. Kids with HIV/AIDS may be discriminated by their peers not to play with them. Or people with HIV/AIDS may not be allowed to engage in certain activities. People used to, for example, avoid them for swimming. Dating and sex become problematic for them. HIV/AIDS is also a chronic and fatal illness. Because of this, despite advanced treatments, it still does not go away. It becomes a chronic disease, and one has to adjust to accepting it for life, taking medications for life, and attending clinics. It is also disfiguring with skin changes, body image changes, tumor disfigurements like Kaposi's sarcoma. And these ones become again problematic for an individual. Once you hear the news that you've got HIV/AIDS, you begin to fear that. The HIV itself goes to the brain quite early and causes problems in thinking, cognition, and perception. And the medications of HIV themselves have serious side effects, which make them difficult to take. And sometimes they may cause mental health problems. Then there are opportunistic infections like TB, nail infections, fungal infections. This disfigure, and again, people begin to shy away from enjoying their lives or joining audiences. So these acute psychological reactions can be usually attenuated or made less once you have got adequate pre- and post-test counseling. So let's first talk about the adjustment disorders. One can adjust the news that they have HIV/AIDS with either changes in mood, changes in anxiety levels, or with changing their behavior. You hear people saying, since that one got HIV, they have withdrawn into themselves, or they began drinking alcohol heavily. So we classify them into adjustment disorders with depressed mood, These feel sad, sleepless, tearful, hopeless, sometimes even wanting to kill themselves. Others adjust with anxious mood. They're nervous, they're panic-stricken, they're always jittery, fearsome, and always worrisome. Sometimes both mood and anxiety are mixed, so you adjust with a mixture of depression and anxiety. Or you can have an adjustment disorder with disturbance of behavior, of conduct, aggressiveness, violence, destructiveness, recklessness, reckless sex, fighting, substance abuse, and other social behaviors. Many times you get a mixture of all of those, whereby you have disturbances in emotions, depression, anxiety, and disturbance of conduct. But sometimes you just withdraw from society. You become inhibited, and that one is also there. Another group of people, once they get the news that they have HIV/AIDS, they feel psychologically traumatized. The trauma of HIV infection begins to affect them. So we have mental illnesses due to this psychological trauma, like acute stress disorder or post-traumatic stress disorder. They share symptoms, but let's begin with acute stress disorder. This is usually a transient mental disorder, which you can develop within minutes of being told that you've got HIV infection. And it will remain so up to 30 days. If it goes beyond 30 days, it becomes post-traumatic stress disorder. Now, post-traumatic stress disorder itself can be one of three types. It can occur acutely within 30 to 90 days, or it can be chronic within up to 90 days, or it can even delay onset up to even 6 months. So what are the symptoms of this acute stress disorder and post-traumatic stress disorder? First, you have to experience the news. You have to hear the news that you've got this. Then you get these intrusive symptoms, like recurrent thoughts of this news all the time, dreaming about it, having nightmares, flashbacks, anything to remind you that you have an infection becomes problematic to you. You may have an altered sense of reality, what we call dissociation, with depersonalization, derealization. You may not even recall details of what happened or how you got HIV. Then you tend to avoid any reminders or memories or even thoughts or feelings of HIV. You avoid people who remind you of HIV, or places where you had it, or which remind you of it, or events or conversations or any activities or situations. Then your symptoms, you may have the symptoms of hyperarousal, like sleep disturbances. You don't sleep well. You become irritable, always angry, verbally and physically aggressive. Your concentration becomes poor. You become hypervigilant. Or you may just have a negative mood. You can't experience pleasure anymore. You become unhappy, never satisfied with anything. You can't express love. And then your autonomic nervous system becomes overactivated with anger outbursts, hypervigilance, as we have seen, heart rates going up, poor concentration, panic, anxiety. And you may want to think that life is not worth living. So you may have suicidal ideation and even attempts. And then because of these reactions, your social, occupational, school function begins to deteriorate. So those were reactions which you get, mental problems which are mental reactions after getting HIV/AIDS. They're not due to the infection itself affecting the brain, but you can actually get the infection, the virus infecting the brain and giving you a mental illness. That is now in this part 3, which we are going to discuss. So how do we classify these specific disorders? Mental disorders, which come to you as a result of the HIV virus going to your brain. You can have anxiety disorders. You can have mood disorders. You can have psychotic disorders. You can have HIV-associated neurocognitive disorders, or dementias, as we call them. You can have substance use disorders. So let's go through them one by one. Remember, these illnesses also occur without HIV infection. And that's that bidirectionality. So let's begin with anxiety disorders. What is anxiety? Anxiety is an emotional response of excessive fear to real or imagined or perceived threats to you. It is the most common psychiatric disorder in HIV/AIDS. Worry. It is characterized by fear and worry, excessively, persistently, going on for all the time, lasting more than 6 months, and impairing your daily functioning. Generally in society, anxiety occurs in about 18%, lifetime prevalence of about 18%. But in HIV/AIDS, the prevalence goes up to 20, 30, even 40% in individuals. And may come as a result of an adjustment disorder, the anxious mood, or it may just come on by itself. The affected individuals have difficulties controlling worry. They're always apprehensive. They're tense, and they have autonomic hyperarousal, meaning that they're always excessively worried and fearful, and their hearts are racing. The symptoms include being shaky, choking feelings, breathing heavily, increased heart rates, sweating, loose flesh, poor sleep, increased urinary frequency, stomach upsets, even diarrhea. Cognitively, one becomes hypervigilant, tense, can't concentrate, and they're always fearful that they're going to die or lose control, or somebody's going to know that they have HIV/AIDS. As we said, anxiety can occur as a result of an adjustment disorder with anxious mood, or as part of generalized anxiety disorder or panic attacks. But any reminder to you that you have HIV, for example, hearing that somebody has died of HIV, or getting any symptoms like a cough, even if it is innocent, or tuberculosis, or a skin reaction, brings back your anxiety symptoms. So you become preoccupied with this all the time, and it begins to impair your quality of life. So Brand studied this and wanted to see the prevalence of anxiety symptoms. And he saw that those people, or disorders, those people who got generalized anxiety disorder in HIV/AIDS were up to almost 3.6%. Panic disorder, which is characterized by recurrent unexpected panic attacks, at least one almost every week, with changes in behavior, trying to avoid panic situations. That occurs in about 2 to 3% of the population of HIV patients. And there are those who then begin to have social anxiety, whereby you fear to be in social situations, weddings, family meetings. You fear negative evaluation. People will comment about me. People will say I have AIDS. That occurs in about 7% of population. Then you may have agoraphobia, which is fear of being in places where you can't easily get out, like being in crowds, or being in a closed home, or being in wedding meetings, or meetings in crowds of people. That occurs in about 1.7% or 2% of the people. But some people get specific phobias, and especially obsessional phobias. And they go and do all kinds of tests to reassure themselves. These disorders, as we said, also are there in people who don't have HIV/AIDS, but in HIV/AIDS, they become exaggerated. What about mood disorders? Mood disorders, or affective disorders as we call them, are really disorders of how you regulate your emotions, either of happiness or of sadness. Of concern to us in HIV/AIDS, depression and bipolar affective disorder. Now, these disorders must be distinguished, those due to HIV must be distinguished from primary mood disorders. In other words, one can get these mood disorders even without HIV. That's that bidirectionality. But both the HIV-associated mood disorders and the primary mood disorders are more likely, patients who have them are more likely to engage in high HIV infection risk behavior and than the non-depressed, and we shall see why. It therefore becomes important to detect, diagnose, treat, and if possible, prevent any affective disorder, whether primary or secondary. If they're not properly addressed, Both HIV-associated mood disorders and the primary mood disorders compromise HIV care symptoms. They increase risk of HIV infection and impact the quality of life of people living with HIV/AIDS. So let's begin with depression. Depression is common in people living with HIV/AIDS, with a lifetime prevalence of about 40%, compared to about 4 to 8% in the general population. And when you go to HIV-infected adolescents, in our work which we did in Rakai, we found that more than 40%, 41% were actually depressed. And remember, up to 18% had ideas of wanting to kill themselves. So how does depression present? Usually you have depressed mood most of the day, nearly every day, for more than 2 weeks, with diminished interest or pleasure in anything that you previously enjoyed. Then you can have either loss of appetite, loss of weight, poor sleep, no energy, feeling worthless or hopeless, having poor concentration, poor memory, being indecisive, and finally, feeling that you should die and you attempt suicide, or successfully or unsuccessfully. These symptoms impair you and you cannot function well. So HIV-associated depression in adults was studied to differentiate it from the primary HIV by Seggane in 2010. And Seggane actually saw that this HIV-associated depression tended to occur in older patients. Depression usually starts adolescents and early youth, but this one was occurring in patients over 30 years of age. And then most of these people did not have a family history of affective disorder. And they had poor appetite, more sleep problems, more energy problems, and they were very critical of themselves and they were indecisive compared to primary affective disorder. Depression in those people living with HIV/AIDS we saw that they had poor adherence to treatment. In other words, having HIV and depression makes one non-adherent to treatment. They give up. They don't take their drugs. And they're more likely to engage in risky sexual behaviors, either for comfort or for saying, who cares? Like not using condom use. Or they tend to abuse substances. Naturally studied this. And they tend to engage in domestic violence, child abuse, and they tend to kill themselves. What about bipolar affective disorder? This frequently occurs in HIV/AIDS in a high prevalence of between 4 to 5%, whereas in the general population, it is only 1%. What is bipolar affective disorder? Bipolar affective disorder can occur either in the manic phase, or depressed phase, or mixed phase. But we are concerned about the manic phase here, where you have at least 1 week of distinctively elevated or expansive or irritable mood with increased activity, increased energy, most of the day, nearly every day, such that people will say, you need treatment. It needs an intervention. These people with mania tend to be very grandiose, having very high self-esteem, very little need for sleep. They don't sleep, they're over-talkative, racing thoughts. They have flight of ideas, they're destructible. They engage in grandiose, over-religious ideas, usually in this country. They take risky behaviors, such as buying sprees. They spend too much money. They have very high libido and will engage in risky sexual behaviors. They have unrealistic deals, business deals. They tend to be argumentative, aggressive, and sometimes violent. Naturally studied this and was one of the first people to describe HIV-associated secondary mania as distinct from primary bipolar disorder. Again, it tended to occur in older age group, had higher prevalence in females, was more likely to not to have a family history of affective disorder. It had more manic symptoms, was more irritable, more aggressive, more disruptive, more paranoid, more sleep disturbances, but they also had visual, tactile, and auditory hallucinations and cognitive impairment. Now, what causes this secondary, this HIV-associated mania? We think that the virus attacks the brain early, or the infections themselves like cryptococcus, or the medications themselves used to treat ARVs. They tend to cause mania. An individual with primary affective disorder who is infected with HIV is considered to be comorbid.
Zoom app is using microphone. I've put it off.
But that with primary disorder has increased infection risk due to the high libido and sexual indiscretions. Usually, a manic episode is disruptive of care needs. They don't comply to treatment. They're non-adherent to ARVs. They have unsafe sex. They abuse substances. Untreated, they have job losses, marital breakdowns, poor quality of life, and they may commit suicide. Its treatment is the same as for primary bipolar disorder, but you use lower drug dosages. What about psychosis? Psychosis is severe mental illness characterized by bizarre delusions, hallucinations, thought disorder, speech and behavior disorder, and deterioration in social, occupational, school, and daily functioning, and no reality testing. Psychotic disorders are very prevalent in HIV/AIDS, either as primary mental disorders, as studied by Lundberg, or as secondary, as studied by Maling. The prevalence of psychosis in people living with HIV/AIDS in Uganda was found to be, in first episode psychosis by Professor Maling, to be about 18%. By Lundberg, who studied HIV/AIDS in hospitalized severely mentally ill patients, he found an 11% prevalence of HIV/AIDS. That's the bidirectionality again. The presentation of the psychosis in HIV/AIDS is mixed bag. They're unlike the primary disorders. They have late onset of psychosis, again, more than 30 years of age. They have auditory, visual, tactile hallucinations, paranoid, bizarre delusions, but they also have affective symptoms, and they have cognitive impairment and behavior disturbance. It is more common in late stage HIV disease compared to the other ones. And it compromises the quality of life if untreated. And again, we treat it with antipsychotics, but we start with small doses to avoid side effects. Now, let's talk about what I call HIV-associated mental disorders. These ones are because of brain damage, direct brain damage. And we have HIV-associated neurocognitive disorders, which we call HAND. We have delirium. We also see lots of epilepsy, progressive local encephalopathy, and mental retardation. These last three, epilepsy, progressive local encephalopathy, and mental retardation, are more common in children who have acquired HIV perinatally. The first two, the HAND and the delirium, are more common in the elderly. We shall not talk about the child organic mental disorders. So let's look at the HAND, the HIV-associated neurocognitive disorders. These are characterized by difficulties in attention, executive function, learning, language perceptiveness, cognition, orientation, memory, judgment. They may be acute, chronic, mild, moderate, or severe, or debilitating, but most often terminal, presenting as dementia. Dementia of HIV infection has had many names. We don't have to go through all of them. But now we classify it as actually compromising of three. One is asymptomatic neurocognitive impairment, whereby one is cognitively impaired, but does not show symptoms, or as mild neurocognitive impairment, or as frank HIV dementia. This was studied in Uganda by Professor Nakasujja. In fact, herself, with Dr. Sakta and myself, developed the International HIV Dementia Scale, which is the cultural and educationally sensitive instrument for assessing HIV-associated dementia. And we found that HIV prevalence in HAND was common with or without treatment at about 31%, meaning that even drugs do not have, antiretroviral drugs don't prevent the presence of these HIV-related dementias. They just produce severity. The treatment of HIV-associated dementia is basically antiretroviral drugs. And usual anti-dementia drugs, the cholinesterase inhibitors, don't help it. So that's how we classify them. These are HIV-associated neurocognitive disorders. They impair activities of daily living. There's the ANI, or the asymptomatic neurocognitive disorder, having at least 1 standard deviation below the mean for normative population on the on the International HIV Dementia Scale. MND has also 1 standard deviation below the HIV dementia scale, but has 2 cognitive domains. The other one had 1, and then the dementia itself has 2 points standard deviation below the mean for normative population and 2 cognitive domains. In terms of prevalence, you see that in about half the individuals, they have it. But those who have ANI, mostly, are about 32, and these people operate normally. Otherwise, minimal cognitive impairment is in about 12% and hard in about 2% of people with HIV/AIDS. Let's talk about delirium. HIV-associated delirium is common. We want to talk about it because it is usually an emergency and associated with the high fatality. This is an acute onset of disturbances in attention, awareness, developing over a very short period of time, within hours to days, and showing that the individual is actually changing, is getting worse with the acute infection of HIV. It tends to occur in times of high viremia or drug toxicities or septicemias or substance use or metabolic disturbances. Because of this, it again shows that bidirectionality. You may not know whether it is the HIV causing it or the substance abuse or the drugs you're giving it. People having HIV tend to develop delirium in about 30 to 40%, especially in those with advanced disease who are untreated. And the mortality is about 20 to 40%. Those have comorbid conditions like HIV, alcoholism, diabetes, or opportunistic infections tend to have high prevalences. And delirium, the occurrence of delirium is threatening to the patient, family, and friends. And they need repeated assurance and support when it happens. But even when they get better, there's a 40% chance of death within a year of having had an HIV-associated delirium. We are about to finish these disorders, and we shall talk about substance abuse. This is defined as use of illicit drugs, alcohol, or misuse of prescription drugs. In Africa, the most common substances of abuse are alcohol, marijuana, cat or cathinone, mairungi, and stimulants like amphetamines. But recently, we see lots of opiates, pethidine, and anxiolytics, benzodiazepines. Pre and post or post-HIV infection drug and alcohol abuse increases the indulgence into HIV behavior. In fact, I remember a long time ago, somebody said that we shall not be able to deal with HIV infection until we close all the bars, because these people forget about safe sex once they're intoxicated. They have multiple partners, they have unprotected sex, they don't disclose their status to partners, they share needles for those who use HIV drugs, and they pass HIV on to others. And they tend to engage in substances. People with HIV/AIDS tend to engage in substances as kind of a maladaptive coping mechanism due to the stress of HIV/AIDS. Drugs and alcohol reduce judgment, they compromise adherence to ART medications, and of course to safe sex. And the personality disorders, whom we saw before, tend to abuse substances. And when they get HIV, it becomes even worse. The drugs which they take or the alcohol weaken the immune system. They may interact with ARVs. They affect the liver, which metabolizes ARVs and becomes inefficient. And they also damage other organs. And they may be associated with other mental disorders, including delirium, psychosis, seizures, depression, mania, even dementia. So substance abuse is an important problem which must be tackled in HIV/AIDS. It is associated with family, social, educational, occupational, and economic problems. And it may be associated with other disorders like anxiety, depression, psychosis, and you need to support families of patients with HIV/AIDS. So in conclusion, mental health problems associated with HIV/AIDS are many, they are varied, they're often bidirectional, they're often neglected, and they have a double stigma. In other words, you have mental disorder, which is stigmatized, and HIV/AIDS, which is stigmatized. That compromises care. Their presence compromises care and any prevention efforts. Unaddressed, they compromise treatment outcomes. They decrease the quality of life of patients with HIV/AIDS. They increase HIV virus resistant strains, and they leave pockets in population which are not affected by messaging of HIV prevention or care. Therefore, we have to integrate mental health care in all HIV/AIDS treatment programs and prevention programs. But we must also remember that the mental health problems of HIV/AIDS go beyond mental disorders to include social and family and community problems, such as the problems faced by orphans, widows, the family disruptions they cause, the multiple deaths, bereavements, poverty, employment, stigma, caregiver burden, educational and occupational difficulties. We also have to remember that now many elderly HIV patients, many HIV positive patients are becoming older. So we have a new challenge of HIV/AIDS among the elderly, which needs special attention because their numbers are increasing. We may have difficulties distinguishing their various problems. For example, Alzheimer's dementia from HIV-associated dementia. So all these issues need to be addressed in the holistic care of HIV. There's need for more research to address the brain impairment in HIV/AIDS and its sequels, and ways for total integration of mental health care in HIV/AIDS and their prevention. Ladies and gentlemen, I'll stop there. These are some of the references. Thank you.
Wow, thank you, Professor Musisi. I've been listening and refreshing my knowledge, and I like the proposal of closing the bars. It happened during COVID, but so people were drinking at night and in very difficult situations.
Yes.
Yeah. So participants, it's now time for us to ask questions, make comments, or seek clarification. You can either raise up your hand, and then we shall give you a chance to make a comment or ask a question, or you can post your question on the chat. I would like, if you're going to do that, please tell us whom you are by name and also which institution you're from. And there we shall respond to you. So Prof, I think Mwanga Faizo has posted something. He says, we know very well that we have some people who discover that they have HIV and then they decide to go viral to give it to everyone. So what advice can be given to such people so that it is stopped? So Prof, you could start with that one.
Yes.
As we get others, yeah.
This is part of that initial reaction, the acute phase. That one is an adjustment disorder, disturbance of conduct. They have reckless sex and they want to infect everybody. They say, I'm not wood, I'm not what, I never chose to have it, therefore I'm going to give it to everybody. Pre-test and post-test counseling deals with that to attenuate those initial reactions. So that person needs post-test counseling. Some countries have gone as far as legislating such behavior and saying that those people could actually be imprisoned until they change their behavior.
Okay, thank you.
I remember a case in Canada It was actually a Ugandan who went around rampaging everywhere from coast to coast, giving people HIV/AIDS. So the law was actually named after him, but I'll not tell you his name.
Okay.
Next
Then,
question.
yeah, there is a question from Nasaka Eva. She says, thank you very much, Professor. When managing mental disorders, do they affect heart or do they affect ART? I don't know what it means, whether
Okay.
mental, yeah.
I think I understand the question. The effect is two ways. One, developing a mental disorder tends to be associated with non-adherence to treatment. For example, you can imagine a manic patient who says, now I am cured. God has cured me. I'm not, and they go their different ways. Or a severely psychotic patient who forgets to take the medications. So it affects not taking heart regularly and will affect quality of the outcome of HIV/AIDS. But also, the drugs used may interfere with the HIV drugs. So you have to be very careful in your choice of drugs as you're tending to treat these disorders. Remember, some of these disorders become chronic and they may have to go on maintenance treatment. So you have to know about drug-drug interactions or read about them as you give them. But basically, the treatment is the same as for standard non-HIV related mental disorders, except for just the dosages.
Okay, thank you. And that's very clear. So Jimmy Ochan has put up his hand. So Jimmy, can you unmute yourself and ask your question? Jimmy, you are muted. So can you unmute yourself and then you ask your question?
Yes. Good evening,
okay.
everyone.
Good afternoon.
Good afternoon to you.
I was asking, could you please help us and tell us some highlight how to advise a person to avoid acute stress disorder?
I'm sorry, I did not hear the question.
Repeat
Come
yourself,
nearer to the
Ochan.
mic. Come nearer to the microphone of your computer.
They should advise on how to approach the patient to avoid acute stress disorder.
He's asking how do we avoid patients from getting acute stress disorders? That is his question.
Okay, maybe I never made myself very clear. Acute stress reactions are attenuated by adequate pre-test and post-test counseling. That is the best prevention. Now, counseling is not done in one session. You may do 2, 3, 4 counselings, including follow-up counseling after the test, post-test counseling. That's what helps attenuate adjustment disorders. When they become severe, you may have to give medications. I steered away from treatment of these various disorders because I thought it would take a lot of time. And moreover, my topic was to address bidirectionality. But amongst those references which I put there on the slide, the treatments are very well outlined. We even wrote a book called Psychiatric Problems of HIV/AIDS and Their Management in Africa by Fountain Publishers. It is still valid, although we want to now to have a new edition of that book. It's about 10 years old now, but it's very good guidance.
Okay, thank you. Thank you. Ochan, can you now mute yourself so that we stop getting that echo? And I hope you heard it clear. Pre-test and post-test and ongoing counseling are very important for managing the acute stress disorders. There's no hand up, but Lubanga Kene.
There is somebody, there's some people
yes?
in chat who are asking questions on chat.
Yes, yes. Are you able to read them, Prof, yourself, and you answer them?
I've read some, but you read and I go and answer.
Yeah, yeah. The next one is from Lubanga Kene. Is it possible that everyone infected with HIV/AIDS are affected by these disorders? In other words, does everybody get the psychiatric disorder? That's what he's asking.
Again, I put up those percentages showing the prevalences. They were not 100%, meaning that not everyone gets them. There are some, I put vulnerable populations who are more likely to get them. For example, children, the widowed, people who don't have support, people who have had previous psychiatric disorder, people in substance abuse. These are the ones who tend to get this, but they may occur in anyone who gets HIV/AIDS. And some of them, like anxiety, almost occur in more than 50% of them, or worries and adjustment disorders. Not everyone gets them, but quite a number of people get them, and they need to be treated.
Yeah, thank you. You had partially addressed the next question. That thank you very much. That is Umukairi. Thank you very much. Shall we get a chance to learn how to help patients on how to go about these disorders, diagnosis and treatment? So I think you had partially alluded that in your presentation, you didn't have enough time to go through the treatment and all that stuff.
But I referred them to a book which we wrote, which
Yes.
should be in your bookstore, which is available in any fountain fountain bookshop. It's
Yes.
called Psychiatric Problems of HIV/AIDS and Their Management in Africa by Seggane, Musisi, and Kinyanda, Eugene.
Yes, and I wrote a chapter on psychosis in that book.
Very much so. Very much so.
Yes, yes. And then Eva is asking, are these people who make others sick get arrested?
Uganda has not passed any legislation regarding people who transmit HIV to others knowingly or even unknowingly. Unknowingly is difficult to prosecute, but knowingly. But there was a law which was in the making saying that if you knew that you have HIV and you have unprotected sex with someone and you have not told them, you should be prosecuted. But they felt that that was going to impair, it was going to stop people from coming out for treatment, and therefore they abandoned that law. So there's no such law in Uganda.
Yeah. Okay. Then Muanga Faizo, is it true that there are drugs that are being given to sex workers to protect them from HIV?
I'm not so sure about that. But what we know about some studies have been done, I think they were done in Nairobi, showing that there were some sex workers who, despite never using any safe methods, never get HIV. And people have been interested in studying those, especially in trying to develop an HIV vaccine. I think you hear about that once in a while.
Yes, please. Yes. So there are efforts to do that, not just sex workers, but any other people who are at risk of transmitting HIV.
Yes.
Okay. Harriet Nerima, shall we be availed with the recording? We really need it. So Lawrence, can you address that question? Because I said yes, but it seems people don't believe me. Devandeke, can you tell us what you're going to do?
Yes, I'll share the recording over the email.
You can put it on YouTube.
Yes, but I'll send a link on email.
Okay.
Okay. So please, Harriet, you're going to get that through YouTube. Then Eva is asking again, is HIV related to genetic birth defects in children born to mothers with HIV? Prof, are you able to answer that? Yes.
HIV is not a genetically transmitted disease, but can be perinatally acquired. You can transmit it via the placenta. We call it vertical transmission, but it's not genetically acquired.
Okay.
But there was also a certain Kule who wanted me to talk about HIV-associated dementia.
Yes, the pathophysiology, that's what he wants.
Pathophysiology.
That's too much for a short time.
I think it's too much for a short time.
Yes.
But you can read about that because that's standard in the textbooks now.
Exactly. Yeah. So Kule, you need to read by yourself. that's a topic of its own. Perhaps we shall look at the people who presented on the psychopathology of HIV in the first topics, so they can give us an easier reference for Kule. So Lawrence, take note of that. We shall sort out so that we give the people an easier reference, okay? Then Dennis, how would a medical personnel handle HIV patients with mental health disorders?
That's a very broad question, because the mental disorders are very many, depends what they present with. I think the key point is to be aware that people with HIV/AIDS get mental health problems. Once you see them, do the correct assessment. If you can't manage, refer. But the disorders are very many. I did not even exhaust all of them. As I told you, for example, I didn't address those which occur in children, especially. But I try to go through them categorically as they present. Premorbid, adjustment, psychosis, affective disorders, and then organic mental disorders.
Yeah. Then Godfrey Ujak he has two questions. Do these HIV-associated mental disorders only occur in advanced HIV or AIDS patients?
No. Because the audience is varied, I'll answer all of those questions again.
Yes.
No, I made it very clear that some illnesses even occur before you have HIV, hence the bidirectionality, and they predispose you to having HIV. And then those which occur in the acute stage, you've just learned the news that you have HIV/AIDS. How do you react? Those occur immediately after up to 30 days. And then there are those which occur in the course of HIV. And then there are the organic mental disorders, the dementias, which tend to occur in the late stages of HIV.
Yeah. So Kule, it is in the whole spectrum of
Yes.
HIV. Yes. And then another question about confounding that substance abusers have HIV-associated mental disorders. Couldn't the mental disorders be due to drugs, not HIV/AIDS?
Aha, that's a very good question for bidirectionality. I put it in the very beginning, and I said they compromise care, they make diagnosis difficult, and you may not know what came first. And the two may occur in the same individual. For example, there's no reason to think that if you have HIV-associated dementia and you become older, you can't have added Alzheimer's dementia. Sure, you can. Or if you have HIV-related or alcohol delirium tremens, there's no saying that you cannot then have HIV-related dementia also. So they can occur together, you know, and that's what usually presents the clinical diagnostic difficulty.
Okay, great. The other one is a bit a technical one. Thank you, Prof.
Bernard Okanyakure from Ginger, Master Ginger, says, what measures have been put across in helping to access for mental illness among HIV patients? I don't know what it means by that. For helping to us or to assess. I have told you that Dr. Nakasuja, Dr. Sakta, Musisi, Wong, and Robertson developed the HIV dementia scale, IHDS, a standard instrument for assessing HIV-associated dementia. The reference is there in amongst those which I put on the slide. You can look it up or just put IHDS in Google, it will come out. Or just put on Nakasuja and IHDS or Musisi, you get it. It is there.
Yeah.
And you can use it to assess it.
Yes, then I think Pinamasco is asking, has Uganda approved use of cabotegravir, some like IV PrEP? Do we use intravenous PrEP now? I don't know whether they have an idea of that.
No, I don't think so.
I don't think so. Yeah, I think what is being used now is the depot, the depot ARTs,
Yes.
Which are taken monthly. That one is being tested.
Yes.
Exactly.
That's the newest system in the market.
Exactly. Yeah. Then Okello Quinton, when does one decide to give psychiatric management, especially pharmacological, because some of the patients just be dealt with through counseling. So maybe, yeah, when do we use drugs, when do we just do counseling?
It
Yes.
depends on the disorder which is presenting. But whether or not you use drugs, psychotherapy is always done. Psychiatric treatment is not complete if you do not do counseling, if you don't do psychotherapy. Now, there are many types of psychotherapies. Some are supportive, some are site-oriented, some are prohibitive, some are group psychotherapies, some are CBTs. Depends on the disorder which is presenting. But pre-test counseling is already psychotherapy.
Yes.
Post-test counseling, which should be done to whoever patient gets an HIV test. So we always do it all the time.
Okay, so maybe we can take the last question on the post for someone who came late.
Yes.
Maybe he's asking.
That individual, there is also a new type of therapy for groups, group support psychotherapy, which has been developed by our group again in Uganda by Dr. Nachimuli. You should read about it because it has won awards worldwide. Go ahead.
Okay. Masiko came late, but he's asking whether the disorders are due to drugs or HIV itself. That one was explained already.
Both.
Both, yeah, both
Bi-directional.
Exactly. So I think let us get Kule. He's put up his hand as our last question, and then I can thank everybody at the end. Okay, Kule, go ahead, unmute yourself and ask your question. Kule, unmute yourself. Kule Ronald. Okay, go ahead.
Yes, yeah, I would like to inquire about disorders you have talked about, because you have talked about the behavioral disorders and then the cognitive disorders. So I would like to inquire specifically about the cognitive disorders, because HIV, like when someone is having the opportunistic infections like tuberculosis, toxoplasmosis, there is formation of tuberculomas, the toxoplasmas, and then the cryptococcoma in the brain. So I would like to inquire about the cognitive disorders. Do they need, like, is it for someone to have someone?
Okay. Let me try. Yeah, he's not very clear. The internet is breaking you off. But yeah, Kule, you are not very clear, but let me try to answer your question.
Is that person
is that person what?
I think I would imagine he's trying to ask, even without those conditions like cryptococcal meningitis, toxoplasmosis, and on, can you still get the cognitive disorders? I think that is his question.
In fact, by definition, tuberculosis meningitis in HIV negative individuals, cryptococcal meningitis in HIV negative individuals causes cognitive changes. However, when we talk hand, HIV-associated neurocognitive disorder, we are talking about the virus itself causing the neurocognitive disorder without the opportunistic infections. You don't have to have them, but they themselves can also give you that with or without HIV. Again, we are talking bi-directionality. Am I clear?
Yeah, very clear. In other words, if we have those other conditions, that is not hand. We need a hand without those other conditions. Yeah. Yes. So thank you, Professor Musisi, Professor Musisi Seggane, that's the full name, for sparing time to share with us the bidirectional relationship between HIV and mental illness. Thank you, participants, for sparing your time. We know you're in the holiday, but you managed to get time to attend. And then thank you, Lawrence, for the IT connection. So thank you, everyone. We hope that you use the knowledge you have learned today for caring for people who are infected